Good morning, everyone. Good afternoon, good evening, wherever you are. Welcome to this session. We're going to be talking about corruption and looking at its different forms, the complexities. We're going to talk about latest evidence and advances from health policy and systems research. We have a series of wonderful speakers covering topics of interest, and we will talk about things like power and politics, also data manipulation, corruption risk in medical education, and also talk about what happens at health facilities, what are the scripts that participants follow. But stay with us. We are going to have an opportunity for discussion at the end of after the talks. So please type your question in the Q&A box. And if you have general comment, please type it in the discussion box. It would be really helpful if you put your questions in the Q&A box, because it will be easy to cover them after that. Thank you very much. And without further ado, I'm going to introduce our first speaker, Dr. Rakesh Parashar. Rakesh is a medical doctor. He has PhD in health system studies, and his doctoral work was under the mentorship of the Health Policy Analysis Mentorship Program in 2017. He works with Oxford Policy Management Limited and leads on a large-scale health system evaluation and learning exercise in Bihar, India. He has over 12 years of experience in health policy practice, and he's particularly interested in building local capacity in health policy and systems research, health policy analysis, and translating emerging evidence into practice. So welcome to give your talk, which is entitled, interesting title, it's a flowing river. Everyone should take a dip. Power, politics, and corruption in implementing a health policy in India.
Hi, everyone. Thank you very much for joining my session. And it is a pleasure to be presenting to all of you this part of the research, which is from my thesis, PhD thesis. I would like to start with providing a quick overview of the overall research that was done. So in the background that the interaction of power, corruption in health systems, and the policy and the delivery of the health services, we understand that all of this has gained a lot of attention and we are all talking about it. But when it comes to the context like India and the policy implementation process, these aspects are very much understudied still. So informed by this gap, we set out to examine the complexities of the overall health policy implementation, but there was a special focus of this study to identify what kind of power and politics play in the implementation. I used the implementation experience of Janani Shishu Suraksha Karyakram, JSSK, in one Indian province, Himachal Pradesh. And as we all know, most of us would know that JSSK promised free service provisions in the public health hospitals in India in year 2011, but still there are reports that people pay money from their pockets in different state contexts in India. And we try to understand the reasons for this kind of implementation gap and examine the role of power, politics, and corruption that may be influencing the implementation. The methodology I used was a qualitative flexible study design for adaptive and inclusive and inductive inclusion of theory as well as analytical frameworks. So broadly, to answer the question of how do the practices of power influence JSSK implementation, what underpins such practices of power, I used an actor-oriented theoretical framework and used actor interface analysis to inform my study. The primary sources of data were in-depth interviews with the policy actors, including the beneficiaries, as well as facility level district office observations and review of the documents. So what we saw in essence was that there were multiple actor interfaces, practices of power and politics, and corruption that influenced implementation. So there were tensions of state and central actors that impeded a lot of implementation decisions. There were vested interest of the political parties and the individual political actors who had connections with the industries who were providing medicines in the system, providing equipment in the system, and there were lobbies of the private providers and the chemists who influenced the JSSK implementation decisions. There were a resistance from the larger hospitals to ignore JSSK resistance and ignorance of JSSK mandate in a way, because they had long time practices of prescribing branded medicines, but it was not very easy for them to adhere to the JSSK list in the start. There was autonomy of the doctor that plays both ways. In some cases, doctor helped the implementation decisions of the JSSK and provided services for free, but in other cases, doctors resisted the implementation process by providing private prescriptions. And corruption came up as a very cross-cutting running theme across the implementation, because there were instances that people were being sent outside the hospitals to purchase services. And one of the senior obstetricians said that everyone does it. Corruption is a flowing river. Everyone wants to take a dip in it. Who wants to die poor in the government system? But I personally assure that poor patients don't have to suffer, which indicated that corruption at one hand is very legitimized and normalized in the system. People see this as a very normal phenomenon, and everybody wants to take a pie of it. But there's also a morality connected to it, that we don't have to charge money or make poor patients suffer. So that's how the corruption played. Power had both positive and detrimental effects on implementation. In some cases, the professional autonomy and moral sense of duty of some actors helped free service provision despite many barriers in the facilities. In other cases, the autonomy of the doctors played out very negatively. There were constant negotiations and the contestations between the different actors at state level, district level, at in the state and district offices, and there were constant negotiation that slowed down the implementation processes. So to conclude, we would like to argue that policy shapes power shapes policy process and the implementation both ways. It can be helpful and it can be constraining. So it's important to identify what kind of power practices can be useful for implementation and what is a constraining force. And the power plays very closely with the corruption and plays in a very interactive feedback loop fashion. So both reinforce each other. We realize that the corruption at times is petty individual corruption, but it is also very systematic and cultural. And corrupt practices influence people. It's relational. When one person in department engages in the corrupt practices like the kickbacks and commissions, others also get involved. Corruption is also ensures the way relationships work. People know each other's practices, and it creates certain kind of dynamics and ties among people. So that's how the corruption played. So we would like to argue then that more analysis of power and corruption and their interactions are recommended to inform the policy practice implementation as well as the health policy analysis research for better policy practice and health systems change. Thank you very much. Very much open to the questions and discussions. Thanks.
Thank you very much, Rakesh, for this introduction to the topic and putting us right into the center of the debate around the politics and the relationships. We'll pick up on some of those issues. Now we'll move to something very different and a different sort of issue and method. But Dr. Shazia Sarahandi will talk about what we know about corruption in non-profit health sector organizations. This is a systematic review of evidence from South Asia. A little bit about Shazia. Shazia is a physician and consultant in obstetrics and gynecology in Pakistan. She recently completed MSc in Public Health at the London School of Hygiene and Tropical Medicine. She has also qualification, which is Master's in Public Administration from Nanyang Center for Public Administration at NTU Singapore. She has received the NCPA International Scholarship Award, which demonstrated high passion for understanding the contemporary problems and performance in public administration. I would like to invite Shazia to talk about, to present her work.
Hello everyone, my name is Dr. Shazia Sajjad. I'm from Pakistan. Before starting this presentation, I would like to thank organizers of 6th Global Symposium on Health System Research for accepting my abstract and providing me this great opportunity of oral presentation. I would also like to thank my co-authors, Professor Dr. Dina Blavanova and Dr. Martin Mickey, for their intensive support and guidance for this systematic review. So the title of this paper is What Do We Know About Corruption, Non-Profit Health Sector Organizations? A systematic review of evidence from South Asia. I hope that this paper would shed a new light on your understanding of health sector's corruption to achieve the sustainable development goals and reimagining the health systems for better health and social justice. So starting off the first slide, in surveys, health sector consistently emerged as one of the most corrupt in many regions, and focus is primarily on the public sector. This is attracting the growing attention from government, donors, and researchers. But so far, the focus has been on the public sector, and yet in many low and middle income countries, a large volume of healthcare is delivered by private, for-profit, and not-for-profit sector. So to fulfill this knowledge gap, and growing attention, and growing influence of non-profits in the health sector, we are examining the research question. We have examined the research question: what are the different forms of corruption within the non-profit organizations in the health sector, and what interventions can prevent and address corruption to uphold the civic commitment of the non-profits in the regional context of South Asia. Here, our research scope is in the regional boundary of South Asia that, according to World Bank grouping, comprised of 8 countries: Afghanistan, Bangladesh, Bhutan, India, Maldives, Nepal, Pakistan, and Sri Lanka. This research is based on the conceptual framework of 2 existing theories. First is the Global Corruption Report 2006 that identified the three elements of corruption: uncertainty, asymmetric information, and large number of dispersed actors. And the second is the interdependency theory of non-profits that argues about the relationship of governments and non-profit organizations as partners. So we have applied the qualitative analysis method approach for this systematic review based on the 3-pronged strategy, and included Boolean search, hand search, and snowball. And we collected data from January 2009 to October 2019 and applied the inclusion-exclusion criteria. We excluded especially papers that were focused on the pharmaceuticals, drug franchise, or faith-based healer, homeopathy, or herbal medicine. Here you can see this Prisma flow diagram. This Prisma flow diagram would show you the course of our research, that how we started from 10,142 papers identification, and then applied the eligibility criteria, carefully screening, and reached to include only 24 papers in the synthesis of the result. So the result of this paper is here. So we found that in first quarter there are 31% frauds and 25% bribery and 19% manipulation of data and 17% theft and 8% embezzlement. And this table would show you what were the common interfaces and functional areas of these corrupt apps. So commonly, I can say that these were the public-private partnership, and government and PO contracting, and community-based health insurance schemes. And the functional area, we identified the management and administration levels, budgeting teams, auditing teams. And for the bribery and informal payment, we have especially found the intersection of the patient-provider interface. So here we can say that these findings not only asserting the immediate matters, but also reconnected several deeper questions about policies, procedures, practices, and influence of culture. So what intervention can prevent and address corruptions? So scholars offer some different kinds of interventions for fraud. For example, for the fraud, measured strategy for government and donors, and change internal mechanism of contract design, tendering, and monitoring. For control of bribery or informal payments, reduce lengthy bureaucratic procedures and offer speedy services instead of bribes or informal payments, or we can say that for declining of the trend of bribes or informal payments, and strengthening of report system and sector-wide electronic data records and proper tracing of supplies and payments. For manipulation of data can be intervened by improvement of electronic data records, open sharing in non-secretive environment, and open access data for ongoing programs. And for theft and embezzlement, disclosing of corrupt act would be the first step. And mandatory training for behavioral changes included specific training of anti-corruption attitudes. So finally, we have some comprehensive list of recommendations for multiple stakeholders, but for shortage, because of shortening of time, we included only for 4 stakeholders. Those are very important. Government should promote systematic inspection and evaluation, and in strengthening of internal regulatory mechanisms, identification and access to information of procurement and regulatory agencies. Government should promote more feminist perspective in public administration for anti-corruption strategies. For non-profit organizations, they should promote ethical and transparent standards for healthcare provision, and promote skills and resources to fight corrupt practices, and revise the salary scale of health workers to avoid financial distress. Donors should promote screening based on track record before doing contracts, and take consent and willingness for independent audits, and promote local NPOs work according to their social need. Health System Global should promote research on corruption in the health systems at national, regional, and global level, and provide funding opportunities for researchers. So in conclusion, I would like to say that the future research might expand this focus to further explore the topic in multiple dimensions. Here you can find the list of references that we use in the synthesis of this systematic review. Thank you very much.
Thank you very much. A very interesting presentation and synthesis of the literature on a topic that we know very little about, corruption in the NGO sector. Our next presenter is Ankita Meghani, and she's going to talk about the quiet corruption of data manipulation, understanding when, how, and why administrative data misreported in Uttar Pradesh, India. A little bit about Ankita. Ankita is completing her PhD at the Department of International Health at Johns Hopkins. She is interested in examining health systems and policy processes in low and middle income countries, and particularly interested in how to strengthen accountability for health, the role of the private sector, and how to leverage digital technologies to improve health system performance. I hand over to Ankita.
Hi everyone, my name is Ankita Meghani and I'm a PhD candidate in the Department of International Health at Johns Hopkins Bloomberg School of Public Health. Today I'll be sharing findings from a research study that we conducted in Uttar Pradesh, India. And the focus of the study has been to understand when, how, and why administrative data are misreported in UP. Before diving into the study, I'd like to spend a minute to set up the study context. First, I want to start by stating the importance of Health Management Information Systems, or HMIS. In a health system, administrative data, or HMIS data, are used to monitor and evaluate health services. They're used to ensure health facilities are functioning effectively. HMIS data are also used to benchmark the performance of different health facilities, as well as to inform program planning. And here on the right-hand side of this slide, you see a schematic of how HMIS data are collected and transmitted within the UP health system, from the primary health center level to the block level to the district level and finally to the state level. And while HMIS or administrative data remain an important source of health information within the health system, we also note that a number of challenges continue to affect HMIS data quality. One of the most visible challenges is perhaps the abundance of paper-based reporting forms and the problems with their storage, as seen on these two photos on the left-hand side. In Uttar Pradesh, however, there has been a renewed effort by the government to strengthen HMIS performance. Particularly at the district level, the government has developed policy guidelines to strengthen HMIS data quality, as well as the use of these data in decision-making. Specifically, to improve HMIS data quality at the district level, in 2016, the government established monthly data quality meetings. And the purpose of these meetings was to vet the quality of data before they're used and reviewed by district leadership during the monthly program review meetings. Second, to promote the use of these HMIS data during these program review meetings, the government developed monthly district rankings based on a set of HMIS health indicators. And as shown in the photograph here, these district rankings essentially rank districts relative to one another every month. The government's intention of using district rankings was twofold. First, they wanted district leadership to use district rankings to monitor the performance of health programs, but they also wanted district leadership to develop action plans to improve the performance of low-performing HMIS indicators. However, despite the implementation of these HMIS policy guidelines at the district level, we learned that variations in data quality continue to exist, and we also learned that in some instances, HMIS data were intentionally misreported. So it was against this backdrop that we were interested in understanding why are administrative data manipulated and what are the drivers of data manipulation. To answer this research question, we conducted in-depth interviews with district, division, and state-level government staff and officials, and we also observed meetings at the district level, particularly data quality meetings as well as the program review meetings that I mentioned. So in this study, we define data manipulation as the fabrication or alteration of data done with the aim of furthering one's personal interests or to cope with systemic pressures. So through our interviews, we learned about 4 types of data manipulation at the block level. Our respondents told us about over-reporting of closely monitored indicators, for example, those used in district rankings, or those that were associated with financial incentives. We also learned about the underreporting of indicators that may reflect poorly on health workers, for example, reporting maternal deaths. Respondents also shared with us how data were often retrofitted to match inventory data left at health facilities at the end of the month. And finally, respondents talked to us about how data were often hidden or removed from presentations with superiors, and this was often data that reflected low performance. After identifying the types of data manipulation, we wanted to understand their underlying drivers. And in this study, we focused on examining how data manipulation is rationalized, what are the opportunities that exist to manipulate data, and how do pressures in a way incentivize data manipulation. Respondents indicated that opportunities for data manipulation were created when block and district level leadership had too much discretion, which resulted in an abuse of power, while at the same time, district staff had no avenues to report their grievances. And with regard to data manipulation, this respondent said, even though I know all of these things are happening at the district level, who do I tell my problems to? Who do I raise my voice to when all the feedback goes to one person? We also found that opportunities for data manipulation were created when district leadership enforced accountability for performance, but not for data quality. And this was particularly problematic because in order to have accurate data to inform monthly district rankings, enforcement of both accountability mechanisms was required. So when we asked respondents, why are data quality mechanisms weakly enforced at the district level, respondents indicated that there were 2 reasons. First, they said that district priorities mirror state priorities, and from their perspective, the state prioritized performance rather than data quality. As this quote states, the trouble is, if the performance is good on the basis of data, no one is going to ask anything about data quality. Second, respondents stated that there were several district-specific challenges that resulted in weak enforcement of data quality. However, they noted that perhaps the biggest barrier was the conflict of interest that existed. District leadership, who were responsible for enforcing good data quality, were also judged on those same data. As this district data staff said, You can look at the data to track health programs, or you can focus on looking at the data mainly as a way to save your own job. District staff also described how performance pressures and the punitive work culture resulted in pressures to manipulate data. They described being scolded during meetings and holding their breath before attending meetings with their superiors. And this quote on the left explains how these meetings created a perverse incentive to manipulate data. Therefore, data manipulation became a coping strategy to improve performance in a short time period. And interestingly, we also learned that some district leaders preferred being a middle-ranking district to draw less attention to themselves. Finally, respondents who rationalized data manipulation did so by explaining the social pressures they felt, especially when it was obvious that other districts were manipulating data, which was reflected in the rapid increases in their district rankings, when those improvements should actually happen over time and gradually. Respondents also described how job security and financial security for one's family was often used as a justification for data manipulation. However, it's important to note that some respondents also shared examples of when they resisted data manipulation. For example, they drew on technical reasons for being unable to change data, like this district staff stated, "We assistant research officers are not data generators, we compile data." Other respondents described flatly ignoring requests. And in this example, this respondent says how they continue to report actual attendance data of medical officers despite being pressured to inflate their attendance. Overall, respondents identified three main factors that mitigated data manipulation. First, they described the benefits of digitizing reporting processes because it increases the transparency and accountability of who enters data when and where. They also described conducting trainings to address technical gaps. However, the most important factor, according to district respondents, was having leadership that not only valued good quality data, but also demanded good quality data in decision-making. There are a couple of policy implications from this study that are worth highlighting. First, it'll be important for the government to consider changing organizational incentives so that there's greater demand for data quality and stronger disincentives for data manipulation. Second, the government should consider building leadership and ownership to generate accountability for good quality data at all levels of the health system. And some potential actions and strategies of doing this is reflected on the right-hand side of this slide. Before I finish, I would finally like to acknowledge my great collaborators at Johns Hopkins School of Public Health, Dr. Sarah Bennett and Dr. Daniela Rodriguez. I'd also like to recognize colleagues from the UP Technical Support Unit who have been excellent collaborators, and I'd like to thank our funder, Bill and Melinda Gates Foundation, as well as our study respondents. Thank you.
Thank you very much, Ankita. This was a very interesting opportunity to hear about this type of corruption, which is quite new. And we're going to have an interesting discussion around the interaction between the formal and informal approaches to managing these situations. I would like to now move to our next speaker. This is Alla Boyko. She's going to talk about assessment of corruption risks in medical education in Ukraine. Awa is a senior technical advisor at USAID Health Reform Support Project, and she leads the Health Workforce Strengthening Objective. Her work involves supporting the Ministry of Health in planning and strengthening medical provision through training. Over to you.
Hello, everyone. I would like to share with you the results of the assessment of corruption risk in medical education in Ukraine. It was conducted in April-September 2019 to understand the motives of corruption among those involved in the education process in medical education institutions. The assessment included 42 focus groups, 57 in-depth and expert interviews, and online survey with 796 respondents covering all levels of medical education in Ukraine, colleges, universities, internships, continuing professional development, and research. Students described corruption as one of the is one of the three categories. Corruption as a way of circumventing rules, for example, a bribery for obtaining a specific grade as an exam, corruption as a means of illicit enrichment, and the fees for something that would have to happen without any additional actions or funds. Both interns and students emphasize that corruption is a consequence of the reluctance of students to study and attempt to circumvent the system. Teachers described corruption more as obtaining undue benefits and less as a means of circumvent the rules. They viewed it primarily as a violation of the law of crime and the practices of obtaining benefits for something that should be done free of charge. Students reported that corruption is beneficial for both teachers and students, but at the same time, it causes harm for both teachers and students. On the one hand, those who want to circumvent the rules and simplify their lives are considered violators, while students who study honestly perceive this situation as unfair. Interns too reported that nobody benefits from corruption, yet they mentioned that all involved may have a feeling of the benefits because all can manage to get the desired things or resolve their problems. The study participants confirmed that the following intermediaries might be involved in the various types of corruption actions: parents, leaders of groups, and teachers. Parents most often act as initiators at the stage of admission to a college or university. The roles of student representatives or teachers' assistants may include informing students of the possibility of or need for a bribe or certain services required for passing the exam, or listing intent and organizing corrupt acts, the collection and transfer of funds, compiling a list of students who gave money. Teachers can be involved as beneficiaries, but also as intermediaries. Teachers who receive money in a corrupt way transfer some of them to the higher officials. In the case of admission to institutions of medical education, students are motivated to resort to corruption by a low level of knowledge. It is worth to distinguish foreign students who often do not have sufficient information about possibilities of entering the Ukrainian universities. At the internship admission, the motives of players include perceived lack of objective criteria for admission to internship and limited places in preferred internship sites. Informal payments by doctors for their enrollment to professional development events are motivated by their perceived lack of state-funded opportunities for advanced professional training and by non-transparent procedures of granting such placement. During the educational process, students, interns, graduate, doctoral students, and doctors are involved in acts of corruption as players. Motives of corruption include non-optimal organization of the educational process and the irrelevant content of educational programs. In the field of scientific research, corruption is reported primarily as payment for publications, avoidance of reviews, falsification of study results, the lack of research funds or equipment, low level of qualifications, and low integrity are widely spread in academia. Pharmaceutical companies involved in academic corruption was reported in the form of payments to research for obtaining distorted study results and payment for editorial staff of scientific journals. In the context of internal and external evaluation, students revert to corruption due to a subjective motive as such as a low level of knowledge, and as well as due to objective issues such as the lack of proper control over the educational process from the administration to for the higher educational establishment, the lack of defined rules for evaluation of students, and the lack of procedures for grade appeal. Degree-seeking students reported involvement in corruption due to either their low academic level or lack of opportunities for professional development of teachers and researchers, or due to overall low level of academic culture. Furthermore, acts of corruption are related to the environment, living in the dormitory, for example, and to employment at teaching and administrative positions. For students, their motives are the need for housing or substandard conditions of living. For staff, the buying of position is explained by a desire of getting materials, benefits, or services, as well as the commitment to get a greater influence on decision-making process. This occurs due to non-transparent staff policy in education and healthcare institutions. This study found that corruption risks are present at all stages of the educational process, from admission to internal or external evaluation, and at all levels of medical training, from training of junior specialists, masters, interns, to postgraduate and doctoral training, as well as continuous professional development. However, these risks vary by prevalence of corrupt practices and their valence. The most commonly subjected to corruption parts of the medical education are admission to the college and universities, internal evaluation of the educational process in college and universities, admission to the internship. The common issue leading to corruption in medical education are lack of clear rules and ineffective system of quality assurance. Thank you for your attention.
Thank you very much, Ala. This was a great presentation. Increasingly, we talk about risk assessment and prevention of public health approach to corruption. We'll touch on this in the discussion. Before we move to our final speaker, I would like to encourage all our participants, quite a few audience and participants, to actually pose some questions. If you could please post them on the Q&A section so we can see them easily. We already have some questions coming in. So our final speaker today is Priyanjali Mitra. She's going to talk about corruption in health facilities, unraveling unwritten scripts using a focused ethnography approach. Priyanjali is a development sector consultant who is working with Oxford Policy Management in India in various policy cycle and across sector health education. Previously, she has been working with SEWA, the Self-Employed Women's Association. She trained for MSc in Sociology at Oxford University and did her BA in Sociology at the Lady Shri Ram College, University of Delhi. Over to you, Priyanjali.
Good morning, everyone. My name is Priyanjali Mitra, and I'm a consultant with Oxford Policy Management, India. Today, I will be presenting findings from a recently concluded study in this oral presentation titled Understanding Corruption in Primary Healthcare Settings in India. As is well known, corruption is ubiquitous in the health system, impacting equal access to quality healthcare for all. In this presentation, drawing on an ethnographic study done in a primary care setting in India, I focus on the following. I try to outline the different forms and types of informal exchanges and transactions between different stakeholders who are engaged in managing and providing healthcare. I try and look at the links to systemic forms of corruption, the ways in which actors perceive their engagement in these acts, and their own rationalization, as well as the function of corruption in the everyday provision of services and management of the facilities. Now, health systems are complex adaptive systems consisting of hardware, intangible and tangible software, and are being shaped by interactions and interrelationships between each of these. The informal exchanges and transactions, an aspect of corruption, is an acknowledged and examined construct of intangible software of health systems. They affect the functioning of systems hardware and software in adverse ways and weakens the system's ability to deliver affordable quality of care. Corruption is undoubtedly complex and multifaceted, and it eludes a clear definition. For the analysis of our data, we draw on the broader literature on corruption, especially to focus on what the operative logic is and the purpose it serves for those who are engaged in it. The one we use for our purpose is this definition from the Cochrane collaboration, which in a 2016 systematic review framed corruption in terms of the abuse of position, power for personal gain. The discussion of corruption has also included an understanding of survival corruption, engaging in acts that make the current adverse working conditions marginally tolerable at the cost of access for others, as well as a social constructionist point of view as a social mechanism which has moral legitimacy. Now, this study was conducted over several months in 2 healthcare centers in India, using a focused ethnographic approach, an immersive approach that involved shadowing, participant observation, perusing through official documents, as well as multiple conversations with facility actors. Now, to understand the forms of informal exchanges, the various forms, their manifestations, and the ways in which different actors are involved, one needs to bear in mind the context in which the actors work in the health facility, with an acute shortage of human resources, procurement and supply challenges, chronic salary delays, to name a few. Within this context, the organizational structure, the positions, and relational dynamics play a key role in the working of corruption. Now, based on the informal and formal relational dynamics that are born of power and gendered hierarchies, corruption manifests differently for different people in the health facility. As is seen here, some actors are made complicit in their actions as they are positioned lower in the ranks, hence unable to say no. At other times, people with the power to hold others accountable and assess performance, those who are higher up, use their positions to demand compliance and silence in these acts of corruption. To analyze our field data, we adapted a typology created by Kankeo et al. 2013, which identifies 3 broad forms of corruption: financial, material, and non-material. Using this typology helps organize the different types and forms of informal transactions and exchanges that are undertaken at multiple administrative levels of the system. Adapting this typology also helps to provide a frame for linking the petty to the systemic. Now, as previously mentioned, corruption exists at multiple levels, in multiple forms, as we can see here. On the one hand, corruption from the highest levels in the hierarchy will trickle down to affect healthcare received by patients at local healthcare facilities. And on the other, multiple acts of petty corruption corrode the system and eat at it from within and below. What then are the actors' perceived roles in the process, as well as their rationalization for why they do what they do? In this regard, corruption acts are seen in 3 interrelated ways. 1, corruption as an adaptive outcome. Practices of informal exchanges of money are deeply entrenched in the system. They're almost normalized and expected ways of functioning. While this depends on the hierarchy and what formal position you hold, we find that petty forms are linked to broader systemic forms of corruption as well. To give you an example, the petty level corruption that occurs in the labor room in a health facility is both an outcome and a cause of perpetuating systemic levels of corruption. It works its way upwards through multiple ladders of the organization and multiple actors. To understand this better, a nurse in the health facility who bears a significant burden of the workload and is responsible for several services like conducting institutional deliveries, immunization, and so on, works under several constraints. There are not enough nurses to distribute the workload, and those who are there are stretched across services for their shifts. This notwithstanding, the labor room postings in health facilities are coveted by nurses. They are prestigious, they serve as an external marker of being a very skilled nurse, and also very financially lucrative for the payments that are extorted from the clients as tokens of appreciation. The taking of this money is justified as necessary to meet the payouts expected from them by the other actors. To retain this position and make sure they are rostered for their duties, they pay a cut to those who decide the roster. They also pay a cut to those who get their salaries released. Failing to do this will either result in the withholding of their salary or them not getting the duties on the roster that they need. These are the adaptive strategies in a system that are expected to regularly pay out a certain amount of money to their supervisors. Corruption is also a response against an unjust system. For certain low-paying contractual positions, it is a moral justification for what is essentially perceived as an unjust system. The pay is not commensurate. The workload is too much. There's no incentive to perform, and there are constant competing program priorities. Here, the actors don't see any harm in engaging in petty forms of everyday corruption and running their own side businesses. They see nothing wrong in engaging such acts compared to what they say are the large-scale systemic forms of corruption that they know of that often goes unnoticed. Corruption is also a coping mechanism. In a system, say from the perspective of the nurses who are working in the facility, given their long delays in the salaries and so on, it is as an incentive given the adverse working conditions that they work under. Now, the wider literature has discussed some of the implications, as you can see here too. So, say poor quality of care in health facilities and increased trust deficit between service providers and patients, highly reduced access to healthcare and increasing out-of-pocket expenditure. All of this are very important implications of the various forms of corruption that we see in the health facilities. Further, it also dilutes accountability and informalizes the management processes because preference is given to actors depending on their relationship. In conclusion, some of the insights gained from the findings of this study, which speak to the wider literature as well, are the following. Corruption has multiple forms, as we know. They often work in conjunction. Petty corruption is as salient as systemic corruption and often goes unnoticed. The broader systemic dysfunctionalities provide a very conducive environment for corruption to thrive. It finds moral justification and a currency in transacting and navigating a deeply constrained system. And hence, it is important for us to take into consideration what the various forms of corruption are, but more importantly, what the actors' own rationalizations are for engaging in such acts. Thank you.
Thank you very much. It is a fascinating debate, and I'm sorry that I'm having, my camera is working now. Thank you. So we have about 26 minutes for discussion, and we have some coming questions, not many. I would like to encourage our attendees to pose questions. I would like to kick off, to first invite you to all to switch on your camera and we can have a conversation. Thank you very much. And Ala, you are not on camera. So the first, while we're receiving questions, the first question to kick us off, I would like to ask, and you all alluded to it, but maybe a little bit more reflection on, you all mentioned definitions and what are we looking at? What exactly are we looking at? Are we, in some cases, it's a petty corruption, in some cases it's more severe, but is this, how do we know, is this corruption or is it a poorly designed system? Is it something that's triggered by the system? And maybe starting with you, Ankita, just the fact that there is no good information system, there is lack of trust, there is no incentive to actually report real behavior and improve. People are trying to save their job, and it is a rational behavior. So I would like to first understand how can we understand that? Is this corruption, or is it just the system which is not functioning well, creates spaces for this survival corruption? And this is very much valid for what you were talking about, Rakesh. So I'd like to start with you both to make some comments about that.
Sure. Can you hear me? Okay, great. That's a really good question. I think in the UP context, we saw that data manipulation to some extent did reflect a disconnect between policy and practice. So on paper, they had very clear guidelines around how data quality processes should be implemented. There should be a data validation meeting. There should be supportive supervision visits. But then at the same time, there were these pressures that existed within the system. There's high workload that came up in a couple of presentations. There were pressures to achieve and deliver on program improvements within a very short period of time. And these pressures, in a way, I think, transmitted from level to level. So the state felt these pressures and the state transmitted these pressures to the district level transmitted these pressures to the block level. So in a way, as several of these presentations alluded to, I think data manipulation really did become a coping mechanism. And in a system where you have variations in district rankings from month to month, if a district is 50 in February, but then jumps to 5 in March, other districts are aware that those changes per se are not necessarily real changes. So then these, I think, ethical values in terms of, we should not manipulate data because it's the wrong thing to do. Those types of values kind of fall short because you're within a system where it's considered okay. It's in a way a socially acceptable norm. And I think the other factors that we noticed, which also in a way incentivized data manipulation, was the work culture. So oftentimes a lot of these meetings that might happen between supervisors and their supervisees were in a way very punitive. And sometimes there was naming and shaming. So from that perspective as well, often data manipulation just became one way to deliver on results in a short period of time with limited resources, limited constraints, and became an acceptable practice. So I think with respect to your question, is this a result of a perhaps, I don't want to say a misdesigned system. It's possible. It's possible that these are consequences of that. And I think that's something worth exploring.
Hello.
Thank you. So over to you, Rakesh, to make some comments about, in your case, what do you think? How do you comment on that?
Sure. I think I would like to agree with Ankita on this, and I also, in my particular study, saw corruption as a construct of a lot of systemic issues rather than a lot of individual-driven dynamics. I think it's the well-designed system as well as a lot of social, cultural context and processing of individuals of those contexts that allows people to think in a certain way. For example, in my particular study, there were certain doctors or certain managers who had taken a stand that they would not like to really involve in this practice of kickbacks and commissions. But those are very few rare examples. Other people were mostly following the norms which were created within the system, and those norms were probably a construct of people feeling disadvantaged working in the public system because there was a constant relational comparison with the peers of these doctors and managers who were working in the private systems, and their kind of earning of money in the social positions was very different from what they were having in the public systems. So there was a constant relational kind of dynamics playing out there, which was again a construct of the say organizational dynamics or the systemic dynamics. So I think there is a lot of petty corruption that plays out in many situations, but even petty individual level corruption from the understanding from my study is very systemic. And when it comes to defining the moralities of the corruption, I think it's a very subjective issue again, and different individuals take different stands on that morality. For example, there are certain actors who saw a lot of patients who were coming from poor backgrounds, who did not really have an option to buy expensive medicines or to go out for the private test from the public hospitals. So they decided that, okay, let us do this for these people, but we'll not do this for the people who are coming from a rather well-off strata. So there is a constant juggling within those individual spaces of these actors about how do they make these decisions. But in general, overall, I think a system which makes these actors feel disadvantaged really makes them engaged in these practices. So that's how I feel from my particular studies data, if I could conclude it that way.
Thank you. And I would like to now build on that and ask Gala, maybe you talked about harms and benefit. Some people benefit from corruption, some people lose. We shouldn't lose. Other work, published work, is now starting to show that it's in a way a social network. So everybody is involved, and some of you mentioned that it's not one person, it's everywhere, it's systemic, it's how things work, how they're expected to work. However, there are some people that benefit more than others. So I was just wondering, in terms of harm, sometimes some of the forms of corruption, it's difficult to see the harm. And in your case, Ala, when you look at education, sometimes does it matter? Is it the issue of how do we deal with that? Would you like to comment on that? I think Ala may have lost her connection, but in this case, I'll move to you, Priyanjali. I really wanted to ask about the informal dimension. How do we actually enforce anything, enforce policy? Because more and more we learn how people make this, they have relationships, they have deals, they work in the social space. And your study is brilliant in a sense, taking a clinic as a microcosm of a society. And there are layers, there are hierarchies, there are people there, relationships, social relationships. How do we actually deal with this if we want to enforce policy?
Thank you so much for the question. I think one of the things to understand, and what we also found through the course of the study, was that interventions are often designed without adequately taking into consideration what that context is like, what that socioeconomic context and the political context of whether it's the state or the district or even a single public health center is, right? And we found that the reasons why a lot of interventions fail is because when they don't take that context into consideration, essentially you're designing your intervention to fail, because you're sort of trying to implement this sort of helicopter process where you're swooping in, trying to implement something and hoping that it's going to function in a highly dysfunctional system, like everybody else also highlighted. How do we get things to function better? I think it definitely needs much stronger analysis and contextualizing the interventions, whether it's technology, whether it's improving data collection or whatever it may be. That's the one thing that immediately comes to mind when you say that. And the other thing is also to, and I think it was highlighted in one of the earlier presentations, is that accountability is often gauged and looked at from this whole top-down perspective, where you're looking at metrics, where you're looking at numbers, where you're looking at the seen parts and the visible parts of the process. Whereas the more sort of unseen parts of this process, which is largely related to how does it really function on the ground? How are the actors perceiving the injustices that they're saying, that they're justifying when they're engaging in corruption? How does that really work? Accountability mechanisms need to be rethought. How are you looking at or gauging the performance of a system that really at the end of the day is full of individuals who are deeply flawed, who have now seen that they don't have incentive to perform. They're in this honeycomb where they're sucked in by these relationships of complicity and subordination and so on. So just to kind of keep it short, I think both accountability metrics need to be really rethought. And when we're designing interventions, we need to look at the context that the intervention is going to apply to.
But actually, you are really raising this issue. A lot of the good governance and regulatory measures that are implemented, they're about finding the culprit, punishing, removing the incentives and opportunity. However, we see that in many cases, the people who are involved in corruption, they are doing it as a survival mechanism. And how can we, and this is a question to everybody, anybody who wants to jump in, how do we take into account this dual role, the fact that people are not doing it because they want to make huge amounts of money, they really have to survive, and very often there is no other way in this tight system. And how do we get that perspective? How do we capture it? You spent so long in this hospital clinic, but I just wonder, from your research, all of your research, how do we capture this perspective of frontline people who engage in these exchanges, and how do we convince the policymakers that this is something valid? This is a question to anybody who wants to come in.
I want to answer this question, that I think to involve policymakers in this decision, that how to minimize corruption in health sector, we must speak about corruption, and we must talk about corruption first in all health sector, and we start from undergraduate studies like a topic. So once everybody know about what is corruption in health sector, then they can prevent this. They can help us to prevent this.
So this leads me, and we're now moving to the questions raised by our panelists. So I'll just start with one that's just in front of me. Definition, we a little bit talked about that, but George Gutaza is asking what your definition of, and some of you said that, but not all. So if you want to say, how did you operationalize it? There is a lot of blurred lines. That's what he's saying. We talked about this. Is it corruption? Is it something else? Do you want to add something on this? In practice, how did you operationalize it? Rakesh, would you like to say something?
Yes. So in my particular case, understanding that there could be so many dynamics of corruption, it could range from financial corruption to a lot of moral issues, to corruption with the documentation, data, absenteeism, all of that. I limited my studies operationalization on the corruption, particularly to the financial aspect, since my original design was not looking at the corruption, but it came out as a very strong issue. So I limited the definition of corruption in my study to financial corruption. That was about getting kickbacks and commissions from the private players in the government system.
Yeah.
If that makes sense, yeah.
Absolutely. Another question that's exactly to you, and good that you are talking, so keep talking. It says, this is Abigail. I'm just trying to scroll to her surname. I'm really sorry. I don't know what's happening. But she's asking, how easy was to draw a line between taking the dip in the flowing corruption river, as you expressed yourself, and not causing the poor to suffer? Because we know that sometimes addressing corruption, if you clamp down too hard on, for example, providers, they may actually not work in the health sector, they may leave. So anti-corruption could cause harm, could intervene in a way, in a very delicate balance, which I think all of you alluded to. Would anybody want to comment?
If I could quickly add my experience on that. So I think it's a very relevant and quite an important question. I think I struggled while I was analyzing my data to really try to understand whether people are really following the normative situation in the society to really engage in those corruption practices, or they're also counting on some of those moral constructs that really prohibit them, or some regulatory construct that can prohibit them from engaging in the corrupt practices. And what I found eventually was that a lot of individual discretion at the level of the individuals who are engaging in that. And also these individuals they're not thinking from a wide systemic perspective. They're thinking from an individual patient's or a client's perspective. So they would make a discretion when somebody probably coming from a lower socioeconomic strata is seeking the services from the health facilities, and they would say that, we understand that there are so many problems in the system, and we engage in these cut and commission practices from the private players, so to make sure that we don't harm the poor patients. And probably this is how, I don't know whether this is their social solidarity bias towards the interviewers or the people who observe their practices, or whether this is how they really perceive their own situation in the system. So it's quite difficult to tease this out. But I think what I perceived eventually after seeing some of these cases and deriving those themes in the research, that there is a certain discretion among these service providers who get engaged in these practices. So their corruption is not universal. So when they are writing branded
it's a result of
from the
yeah.
Yes.
So I wanted,
yeah.
because we have a few more questions. So thank you very much for your answer so far. But I wanted also to sorry, I interrupted you. Do you want to conclude?
Sorry. No, I was just saying that there's a discretion that plays here, looking at the social situation in those facilities, and the doctors also behave according to those dynamics when different patients come to them, and they make a decision according to what they think is right for them.
Exactly, and we see this in many settings. There is a lot of discretion in formal relationships. Thank you. The other question I want to ask now, I think I'll try to join, but Shazia, you can answer this because you did a literature review. Patrick Wilson is asking whether we have any examples of where policy intervention of health system led to reduction in corruption. Do we have so many positive deviants? Obviously, it's rare, but do we know something? Was there anything you found, example of where things worked, led to reduction in corruption, improvement in outcome?
What we, in my study, that I found that the extent of corruption in South Asia has had a wider concern regarding poor governance, which in turn has been associated with poor economic performance and poverty. So it has been prevalent in all developing countries, but it is more profound in South Asia. And in my study, that I found that the link of government with the non-profit sectors, like in the public-private partnership, or like in the government contracting with the private sector as non-profits, we analyze that this corruption is transferred from, we can say that it started in the public sector, but it come from public sector to and involve the non-profits also. And what we analyze that in South Asia, a lot of healthcare is delivered by the non-profit sector, and people have a great trust on these organizations. But once this corruption is that once we found that these organizations are not immune for corruption, that it becomes very difficult for government and donors, so whom they can trust, and how they prevent the corruption in the non-profits. And so what we thought that what in the discussion section of our literature review, we think that this corruption can be prevented by forming a legal structure for non-profit organizations, and to minimize the bureaucratic, lengthy bureaucratic procedures in these organizations. Like, these organizations are accountable for many people, like in government, donors, and for the civil society. So to minimize this corruption in the non-profit, we need to shorten the lengthy procedures of bureaucracy.
This is a very interesting point. The answer is, are NGOs better at managing corruption? Or the answer is it depends. It's not necessarily the case. But I have a final round of comments. Actually, we're given a slight extension to the session, so that's okay. Many of you are interested in digitization. I would like to know, so we have very mixed experience, and digitization has seen as one of the tools for improving accountability, reducing corruption. And we have, so for example, in some settings, like Bangladesh, for example, we have statistics of doctors who are absent published online, and nobody is acting on it. It's not even taken seriously. We don't know whether this is actually true or somebody. But indeed, some posts we are seeing a lot of absenteeism, but this doesn't lead to any action. In a way, sometimes it's difficult to see in what case can digitization work. Do you have any good examples that you could give? Even if it's not just corruption, but accountability improvement. I know, Ankita, that you work in this area.
Sure, thanks for that question. I can get started. So I think digitization certainly has potential. So for example, if we look at Uttar Pradesh, the state of Uttar Pradesh, they started digitizing data entry starting at the block level and upward in the health system. And very rapidly, I think having access to digital data meant that folks could look at time trends over time. They could look at how services are changing month to month. They can analyze a lot of data, which can give them a sense of potential outliers in reporting. It can tell them about how other data quality metrics, such as completeness of data, are changing over time. So I think digitization in one way actually is very useful when you look at it from the data quality perspective. You can monitor data and changes to data quality over time. But I think digitization doesn't solve all of the problems. It really also depends on how these data are being used and viewed. So for example, as I briefly mentioned in the presentation, data metrics were used in a way to reprimand poor performance, which again led to data manipulation. But if data are used in order to investigate why there are areas of poor performance, so for example, if an indicator around ANC coverage is doing poorly in one area, but then other data metrics are used to triangulate reasons for that low ANC coverage. Is it the lack of commodities? Is it the absence of certain HR staff? Is it other reasons? I think data could be used better. So I think digitization solves part of the problem, but it also depends on how those data are used and whether those data are really used to understand the problem better and then develop more targeted action plans for improvement.
It's a shame that I think internet connection, but there's been a lot of, for example, efforts, open procurement, open government, or these approaches, but you're raising really important issues. Anybody else would like to jump in on this? Rakesh, did you have anything on digitization?
I think, yeah, I have similar views to what Ankita presented. I think when we talk about the digitalization, I think there's a lot of, again, a dynamic that plays out in the health facility settings or in the systems or in the culture. That, if people really want to find their way out from those monitoring systems, they will always have that way out. So we'll have to focus on why people really want to, engage in those maladaptive behaviors. If we are not being able to deal with that, there's always a problem with the digitalization system. So I think that's a very important thing to look at when we look at some of these high-end digitalized systems in LMIC settings.
Interesting, thank you. So not to be over optimistic, but some promise there. So I would like, so we're towards the end of our session, we're given a few more minutes to, so I would like to do the following. I would like to ask each one of you, based on your work, your experience, your observation, and please use your gut feeling, because we know very little what works. So actually you could tell something really new. What do you think is most promising as an approach to corruption, not to solve it, but an approach to start with? What would you do? And then the second one is research agenda, just one liner. What do we need to study more in order to progress towards a better understanding of how to manage corruption and respond? So I would like to start with Priyanjali. So 2 questions. First, what can we do? What possible approaches do you see promising? And second, research agenda, gaps. What should our funders fund?
I think coming from the experience of being involved in a study over several months that was deeply immersive and very ethnographic in nature in terms of the approach, the one thing I would say as far as evidence generation and the research agenda is concerned is the adoption of more anthropological approaches to generating evidence, where frameworks, pre-prepared frameworks or notions of what corruption can be and is not something we are married to as researchers, but a lot of bottom-up generation of evidence from the perspective of those who are within the health system, even if that is in a microcosm such as a public health center, that really needs to be an important point on the agenda as far as research is concerned. I would like to say less about what are the best solutions to the process, mainly because the study was supposed to just illuminate what is it that is happening on the ground. But those are my 2 cents. Yeah.
Is there something from what you have learned that you see as promising area for solutions? Not the actual solutions, but something.
So I'm going to go back to, and maybe this is slightly sort of different from the way, say, Ankita looked at her data and the approach in her study, just to say that it's very easy to manipulate a system of digitalization if you want to get out of it, something that Rakesh said. It's very easy to show that you're performing as a health center or a district to make sure the metrics are just right so that every time there's a supervisory visit, you look great on paper. So one way to look at, and probably a solution in this regard, is to focus a lot more on what is the process that the health actors are going through in implementing a particular scheme. So accountability for the process and not just the outcome. And when I say that process, there needs to be supervision also on the process, and not just how many deliveries did you do per month, but how did those happen? What are the challenges you faced in conducting X number of deliveries in your health center in a particular month, for example?
Thank you, brilliant. I would like to move to Shazia. What are your areas for possible solutions in the future for people to look at? Not that you give it now. And what are research gaps?
I think that it's important for all health workers, like being a physician, I would like to give a message to all health workers that they should bring a change in their behaviors. So because this corruption, like anti-corruption efforts, required behavioral change in all health workers, and then that will helpful for everyone, like in benefits of patients and in benefit of our governments and for everyone. And for the research agenda, I think that to generate evidence, we need to promote the doing research that is uncommon in developing countries. Like in my own country, I think that there is very less research institutes who are going to do this corruption research specifically. So I think they should include more researchers for this health sector corruption. So together we can generate more evidence, and together we can help to create anti-corruption efforts for all developing countries.
Thank you. And over to you, Rakesh.
I think my learning on the corruption is that we should try to look at interventions that create those conditions within the system which make people feel less disadvantaged, because a lot of it comes from that constant feeling of being disadvantaged and then getting into some maladaptive practices. So that's one area. And on the research part on the corruption, I think probably it's important to get engaged into some kind of action research, because even if you look at the systematic reviews, those are available. We don't know a lot of interventions that can really change corruption or can shift corrupt practices within the health system. So I think it's important to get into those more adaptive learning based research exercises that allows us to learn more about what can work in local contexts.
Thank you. And finally to you, Ankita.
I agree with everybody's suggestions. Those were great suggestions. I think based on my study, I think one thing that I'm curious to learn more about is if technical resources, if human constraint issues, if those resource constraints are actually addressed, does that mean that there's less pressure to manipulate data, for example, or to engage in corrupt practices? So, I mean, since my study focused very specifically on data manipulation, I mean, I think a lot of these were really just pressures where people had to deliver in a very short period of time. There were national campaigns happening, performance was being monitored very closely, and in a way, people were asked to do things which were potentially unfeasible. There's also issues of guidance and actually having public health capacity. So at the district level, a lot of the leadership, for example, the chief medical officers or the district magistrates, they aren't necessarily public health practitioners. They don't really think about necessarily program improvement. Many of them come from a medical background. So thinking also about the public health competencies and whether those types of technical resources that allow program improvement actually exist, I think is one area that I think may potentially reduce pressures to manipulate data or engage in corruption, for example. I think in terms of future research, we have some sense of what some of the underlying drivers of data manipulation are, but I think we need to have a better sense of what will actually work. And I think having the perspectives of folks at the front lines, at the district levels, at the block levels, that understand the intricacies of how dynamics work between different actors, and there are also hierarchical relationships that they have to maintain. So I think being able to get their preferences in terms of, what are those types of strategies that could reduce data manipulation, I think might be a next step for this area.
Thank you. This was wonderful, and I took notes, learning from all this. I would like to now give just 1 minute, final remarks. So what I felt we talked a lot about is the multiple drivers of corruption, but also trying to understand the multiple causes and what's a cause and what's effect. I think we are a little bit still learning, because it's a circle, it's self-perpetuating, but certain practices trigger other responses. So it's interesting, where is the beginning, what's the end? And really thinking of it, and not thinking of corruption, these practices that we talked about, not as a moral problem, but as a systemic problem, as Rakesh, you were emphasizing, and everybody was emphasizing. Is it maladaptation? We really need to understand better. And interestingly, COVID, what we saw in high-income countries, the temporary crisis maladaptation due to COVID open space for corruption. And you are very aware how many scandals we have right now in a lot of high-income countries. I'm familiar with European Union, and it is all over the newspapers, because suddenly a space was open where the usual routines were disrupted. And so again, this maladaptation that you all talked about creates an opportunity. And then at the same time, we have the next step. What is the informal relationship between different cadres? What's the hierarchy? What's the social role and trust? As you said, Ankita and Payajali, it's really about the trust, whether you can function and survive and keep your job if you are really honest and report. It is a part of this. The formal is also the informal. And finally, I think what the further research should strip down all these layers and try and understand what is social, what is due to a system, what is due to the social relationships. But finally, I think I would like to conclude, we need to bring the people who are in the encounter a bit more. And you're all doing that, you're researchers, but I think getting the information, what would actually make them not do these practices, and try to open up some sort of space to understand that in a more systematic way. I think that's where we are. And I would love to hear more in the future of this type of research. So I would like to thank you all for your time, and thank for our presenters and attendees. And to conclude the session, thank you very much.
Thank you, everyone.